Good afternoon, everyone, and happy Friday. Welcome to the 2021 SCID Compass Summit. My name is Freema Four. I am the Virtual Care Associate for the Immune Deficiency Foundation. Here with me today is Saira Haque, Director of Data Interoperability and Clinical Informatics at RTI International. Saira will be presenting on telehealth, opportunities for use with American Indian and Alaska Native SCID families. If interested, a PDF of the slides Saira is sharing can be found and downloaded on the session's main page on the virtual platform agenda. A recording of the session will be uploaded to the virtual platform site shortly after the session ends. If you have any questions, please enter them into the chat and they will be answered at the end of the session. Welcome, Saira.
Thank you. Thank you all for having me, and thanks for sticking with it and coming until the end of the summit. I know it's tough to have a full couple of days online. So today I'm going to talk a little bit about telehealth, particularly for Native American Alaskan tribes. This is the standard disclaimer that we have. I think you've seen it on all of the IDF presentations. And let's see, we can go on to the next part. So I wanted to just clarify some terms. HRSA uses the term American Indian and Alaska Native to really refer to what some might commonly call Native Americans or tribes or tribal communities. I'll use all of those terms interchangeably, but that's really what I'm referring to. So first, we'll go into some definitions. Then I'll talk a little bit about why we did some of this work, get into what we did, and then talk about the factors that we learned about, and then some opportunities for practice and policy, and then hopefully we'll have some questions together. So first, what is telehealth? A lot of people have a lot of different definitions for telehealth. Sometimes people refer to it as real-time interaction, otherwise remote patient monitoring. We're really taking a broad view of telehealth and thinking of it as an umbrella term for virtual care generally. And so regardless of the type, it involves interactive electronic information sharing, and that can support diagnosis, treatment, support functions, and care coordination and management. So really, we're taking a broad view for telehealth for this work. So again, I said this at the beginning, but there are specific definitions around the term American Indian and Alaska Native. And I know that there are a lot of preferences that people have for terms. And so this is a term that really the government has been using, and it refers to a broad swath of tribes and tribal populations. So just as, with any ethnic group or any group, there's a lot of divisions and there's a lot of different types. We can't paint this population with a broad brush either. And so where we can, we will talk about things that are specific to tribes, but a lot of what we learned applies to tribes generally. So first, why did we worry about this? Well, there's a couple of reasons. One is that these populations often have disparities, and that one reason for that is lack of access to care. Reservations are not necessarily located near large population centers, and those who maybe do not live on a reservation might not have access to care in the way that non-tribal populations do. As a result, there's increased mortality from common chronic conditions. And so just as there's increased mortality for common conditions, for uncommon conditions such as PI and SCID in particular, those kinds of disparities are exacerbated. So really looking at telehealth as a way to expand access began earlier than telehealth in some other areas, really in the 1970s. And as you can imagine, the technology in the 70s really couldn't even support a virtual meeting such as this, let alone a robust telehealth encounter. So as the technology has improved and broadband has improved, so too has the type and amount of services that are offered. And then in terms of SCID in particular, there are some populations within the American Indian and Alaska Native communities that have a higher incidence of SCID than the general population. And so because of that, and because of some of the access issues described earlier, and the needs of those patients and their caregivers, we thought we should look and take a really kind of closer look at what some of the needs are and then some of the barriers and facilitators. And one other point I wanted to mention is that not only are there access issues, there are issues generally with SCID because it's such a rare disorder, and there are not that many providers nationally who are experts in the disease. And when you think about where some of the populations are located and perhaps some of the geographical and transportation barriers, that really puts telehealth in mind a little bit more. And so we thought we should conduct an environmental scan to learn a little bit more about telehealth use in general among these communities and see what lessons could be applied. And so that and what we'll come out with and what we'll talk about a little bit more are some considerations for telehealth use that are culturally competent, and then also some implications for policies and for practices. So that will also include some barriers and facilitators. So what did we do? I said we conducted an environmental scan. What does that mean? Well, the environment is, what that means in this terms is looking at both the literature, so what's been published, and then also talking to people. So people who either provide care for these communities or who are members. And so looking at the literature review, that's what's been published. So we looked at both peer-reviewed literature and gray literature. And so what that means for those of you who aren't as enmeshed as this as I am and spend all their time there, peer-reviewed literature is what you see in medical journals. And so that means it's been reviewed by peers, so other people who might be parts of that academic or practice community. Gray literature is also often very important, but it doesn't have that peer-reviewed component, and oftentimes it's intended for more of a lay audience versus perhaps more of a technical or medical audience. And so we looked at terms related to tribal communities, to SCID, to telehealth, and then we actually expanded a little bit more beyond SCID because there wasn't that much out there to look at other rare diseases and genetic disorders. And we searched a number of different databases. There are a number of databases in which this literature can be housed. And while we did have some duplication, we wanted to seek a broad brush, so we looked across them. And as you can see, we identified 54 articles that would be relevant for this. We saw some more that came up, but they weren't really relevant for what we were looking at. In addition, we talked to 2 people who provide care via telehealth for SCID, and to 4 caregivers who are members with or identified with this population who either have a child or grandchild or otherwise provide primary care for someone with SCID. So what did we find? There are factors that are related to the patient level, the site level, and the site meaning the site of care, and the environment. And we'll talk about these a little bit more in detail, but I just wanted you to see this so that way as we go into each category a little bit more, you can see what we're looking at. So let's start with patient level. So patient level, and when I say patient, it's really patient or caregiver, because I don't have to tell all of you that when we're talking about a SCID patient, we're really talking about the family, because even the most advanced baby is not able to provide care for themselves. And even as the babies grow into children and children to adults, oftentimes the whole family is involved. So a couple of things that came up. One is access to reliable devices and networks. So there was some discussion both in the interviews and in the literature around making sure that people had access to the internet, an internet-enabled device, and had consistent access. So sometimes there wasn't really consistency in having high-speed internet or in having a device or having it paid off, that kind of thing. And so you can see some quotes there. I won't read them to you all, but you can see that there are a few quotes from the interviews that really kind of illuminate or highlight the points that I'm making. The second is digital literacy. So not only does one have to have a device, they have to know how to use it. And so if someone is not that familiar with maybe smartphone use in general, texting, email, then it makes it difficult to have a quality telehealth encounter. Or maybe they're kind of familiar, but not really. That happens a lot. So not only is health literacy important, but also digital literacy at the patient level or caregiver. The next is patient preference. Some patients feel more comfortable with a telehealth visit for a variety of reasons, while other patients might prefer a face-to-face or virtual visit. Some of the reasons for those preferences include a comfort level. Others might include the barriers being so overwhelming that they would prefer a virtual visit. So perhaps if they have to take a day off work and drive 500 miles and finances might be a concern, all those types of things, those might overwhelm. Those barriers might be so overwhelming that while they prefer an in-person visit, in practice they prefer a virtual visit. The next one is telehealth, or travel, I'm sorry. So, some people prefer to travel. They feel like they could really focus on providing care if they're at the location. Others have perhaps family responsibilities. They have other children to manage. Perhaps they have a job or other things to consider. And so for them, travel is really more of a hardship. And so by offering telehealth, and fewer people are lost to follow up. And then trust and access. And this is really an important one because oftentimes sites, it's already a shortage of SCID providers. And then if you think about those providers with SCID who are trained in or who have experience in providing culturally competent care, then a small group becomes even smaller. And so by offering services virtually, we might be able to expand the reach of culturally competent providers. And so that is an important consideration for patients and their caregivers. The next thing to talk about is site level factors. And so site includes both the originating site, so where the patient is located. So perhaps if they are at a clinic near their house, or if they're at maybe on the reservation, that sort of thing, getting care there. Or the site can mean where the provider is located, the distant site. And so that could be maybe a provider at a tertiary care center or where they normally are located. Regardless, both sites have to spend a little bit of time on infrastructure and sometimes money. And so some of the things that came up there are the costs of the program. So that can include technology and broadband costs. It could include the costs of maybe having like a telepresenter or a telehealth coordinator or adding on to somebody's additional their job. Strategy, how does telehealth or virtual care fit in with the overall strategy? A partnership, so it's important to have a partnership between the two sites for information sharing, coordination, and then also thinking about next steps and physician orders and who's going to actually carry those out. Champions, and you can see the quote there about champions. Really, both sites need to have someone who's really championing virtual care use and to help overcome some of the barriers and some of the change management factors that can occur with any kind of change, let alone switching to a mode. That's less important now with the pandemic than perhaps it was before, because before the pandemic, telehealth was really not as common. Overall, nationally, the rates for outpatient visits were in the single digits. And of course, now that we're in the, year 1.2 or so of the pandemic, more people are familiar with it, both patients and providers. But I wanted to include this because there's still going to be some work that's needed when thinking about telehealth post-pandemic. The culturally competent providers and staff and making sure that they feel that their knowledge is being used in the best possible way. And also any training that can be provided so that we're not just relying on the same few providers over and over again. Telehealth can be used to provide provider-to-provider education in that way. Physical space. So physical space is an interesting one because oftentimes in a clinic setting, providers might share an office because they go to the office between patients and they write notes or something like that. However, in a telehealth visit, a shared office space might not really work for privacy reasons. But then do you take a whole patient room for a provider to sit there and provide a visit? Similarly, in the distant site, if the patient is at home, you have to worry about their broadband, their lighting, their technology use. But if the patient is at a distant clinic, then similarly, a lot of clinics are not just, flush with space, but have space considerations and concerns. And so you have to think about who's going to room the patient, where that patient will actually be to have the visit, and how that fits into the overall workflow, which is the last item. And so, those are a few things to consider. And particularly if you look at that last quote about physical space, that refers to the patient in the home. And oftentimes, particularly for skin conditions, which as you all know, do happen, a small difference in lighting can make a big difference in how something like a rash is interpreted. And if someone is at home, the lighting might not be consistent, and there might not be, or there probably isn't a provider there to provide another side of eyes for interpretation. And so then you have to really kind of think about how to interpret and how to sort of make the most of the visit that's there, and see how to interpret that way, and then determine what needs to what needs to happen next. Is a physical visit indicated? Perhaps some pictures, or there are other things that can be done. And the last one is environmental factors. And so when we're talking about the environment, it's really about kind of the technical environment at large, like the community. So the first is broadband access. Broadband access is a large problem in the United States generally. For a developed country, we have great swaths of the country that are not supported by broadband access, still have dial-up, still have satellite, or maybe don't have anything at all, and people have to drive to another location near them to have access. This is exacerbated for the Native American communities because many reservations are large and are located in areas that are adjacent to broadband deserts. And so some of the caregivers reported having to go to another site to have access. And so then a person is still traveling, which might not really overcome some of the geographic and travel barriers that we discussed earlier. So that's one. Another is being able to afford it. So even if access is available, can a patient and caregiver afford it? Can they afford consistently to pay for access and the device that has access? So a cell phone or similar, and then that coverage. So those are real considerations. The second involves telehealth laws and regulations. There are a number of different rules and regulations that govern telehealth, including state level factors, being able to provide care across state lines, payment parity, and then also kind of restrictions on who can provide care and where they can be located. While many of those have been lifted during the pandemic, it is not clear how many of those will be retained after the flexibilities will be retained post-pandemic. So it's still important to kind of keep an eye on those and see what as the future is unfolding. I think just yesterday there was legislation and testimony in Washington around telehealth. And so that's going to be an area that not only affects this population, but really affects everyone generally. And so now that we've talked about some of those factors, I wanted to take a moment and talk about culturally competent care and what that means. Now, first, I wanted to mention that not all tribes are the same, not all communities are the same. Some of the factors will be different. So I kind of wanted to start with that, even though I know this audience is likely aware of that. However, there are some things that kind of are consistent across communities and things to consider. One is that, there is a very long history of tribal communities and the way in which healthcare has been provided to them and other types of services by the government. And so it's really important to consider that history when thinking about trust and why people may or may not have trust in the system, why they may ask more questions, why maybe they want to seek other guidance. And so certainly anyone, a lot of people get second opinions and things like that, but there are underlying systemic factors that might contribute to perhaps lack of trust or mistrust or that sort of thing. And so particularly when you have a baby that looks perfectly healthy, but perhaps has had something come from a test result, they might think, well, my baby looks fine. What is this test result? I didn't even see it. So those are things that we should consider in messaging and communications, in pamphlets that are handed out, that sort of thing, to really make sure that things are kind of taken through stepwise to do everything that we can to ameliorate some of those trust issues. The second is thinking about ways to incorporate the patient and their caregiver and family's cultural practices and beliefs. Now, certainly there are times in which perhaps in an emergency, perhaps when someone might be immunocompromised, post-transplant or something like that, where there really is not a place, or it's very difficult to incorporate things such as herbs or other tribal practices or excess visitors. However, not every single time is one of those times in the whole care trajectory. So there are times when perhaps some of the rituals can be included, where perhaps there might be local resources if a tribal elder cannot make a visit. Or is there a way to use telehealth to use a Zoom? And so that way, someone from a tribal elder or someone who provides care at the reservation or wherever the patient and caregiver lives could maybe be involved that way. And so that's one thing to kind of consider about being maybe a little bit creative and thinking about where are there times when the patient and caregivers practices can be included so that they can feel a little bit more comfortable. And if we can have maybe a marriage of traditional medicine or Western medicine and cultural practices of these communities. The next is considering the need for support groups with members of the community. SCID is already a rare disease. It's already a disease where maybe people feel like, or disorder where people feel like, gosh, I don't have anyone in my community to talk to. And then when you think about the sub-community, you're even dividing that even more. So telehealth could be used to perhaps provide maybe like a virtual support group or provide ways for members of the community to talk and just share experiences and learn from each other and get support so that not only are you talking to someone who perhaps they themselves have the same disease as you, or maybe they're a caregiver or parent, depending on the age, but also can kind of share about some of the cultural considerations because it is different. And I think it's important that we recognize that. Some other specific considerations that arose, a couple of things that came up pretty consistently in the scan were that oftentimes, we are living in a fast-paced society. Providers have 15 minutes for appointments. I'm from New York. I talk fast, I walk fast, I do things fast. And, people all have their own sort of cultural and the ways that they're used to doing things. However, that might not necessarily resonate with this community. And it came up a couple of times that it's important to allow time and space for silence, and also for people to gather their thoughts and to make sure that there's really enough time to allow for the patient, if they're old enough, or patient and caregiver, to make sure that their considerations are addressed and to offer some of the cultural considerations, to say that, yes, we have in the past, we have a local person from your tribe here. We have a local chaplain, for instance. Sometimes it does happen. Or if we don't have one, we can Zoom in someone might not even think to ask that. Or it might be that there's so many other types of medical questions that doesn't come up till later. So making sure that there's enough time and not only physical space, but mental space, if that makes sense, to kind of address some of these other considerations. Also, to consider the use of words. Words are important and have power. Just as though in the beginning I thought it was important, and it probably was, to identify terms and definitions. Sometimes it's important to really think about, what does a word mean and how will this be interpreted by people in this community? So some things that came up were using third person language, so not necessarily saying you, your baby, things like that, but keeping it more like people in this situation, this might happen. That was something that came up. So using that third person language can help so that people don't feel attacked or feel that maybe someone is being too forward. There are different kinds of ways that people speak in different cultures, so that's something that came up. Another is communicating timelines. A provider might say, and I think we've all had this experience, oh, okay, well, something could take 12 to 14 months. They give a range. Well, and then the provider may go on to say, but that can vary based on X, Y, and Z. people will kind of hang on to that 12 to 14 months. That happens across communities, but this is something that came up pretty often with this community as well. So it's just something to keep in mind, perhaps broaden the range, because that's what people will remember. And then also, I said it before, and I think it bears repeating, about to the extent that one can address cultural considerations to do so. And it's hard to expect everyone to remember, yes, these are the things that we can do. So might be worth it for providers to develop a cheat sheet, have something that you can have like a little note for the EHR. You can have, there's binders of resources, you can add that. There's a lot of different ways that some of this knowledge that people have institutionalized or kind of thought about, who've provided care for a long time, can use to share their knowledge with others. And then also to involve the rest of the care team, social workers, etc. And then here I thought were some good examples. I know I just explained it, but I thought these quotes were just really helpful to explicate some of what we discussed, especially the third person language. So, especially when you think about, oftentimes you talk about risks and rewards. It's a very common thing. The risks are X, Y, and Z. This is what can happen. We want to be careful that people don't interpret it as your child will have X, Y, and Z, but more about the procedure. And that is what people mean. Providers don't mean to say your child might die because of this. That doesn't happen. However, it's important to be maybe a little bit more cognizant of how things might be interpreted. And so just using third person language, actually, that might be a good practice generally, but just to have a little bit more knowledge of that here. And this is based on, actual experiences that people have had. And same thing with the timelines, not to, just assume that things will be taken literally. And so then you might want to, expand or be a little bit more careful with language. And then the third one is training. Oftentimes, residents, they train, they rotate in and out, and that goes for medical residents, pharmacy residents, nursing trainees who are brand new. People rotate on different rotations and then they move on. You don't know where they'll wind up. Also, who is going to train them every single time? So perhaps having decision aids or guidelines or things like that that can help when providing culturally competent care would be useful. And also making sure that they know, what is allowable and what is not, and at what different times. Kind of like what I was saying before about herbs and such. There might be times in a trajectory where it's perfectly fine to incorporate, but there might be other times where it's really it's more challenging if you're like in a boiling water phase, for instance. So it's important to kind of have those things explicated, so it's not just a blanket no, but it's, well, no, not right now, and then kind of deciding when something might be possible. So I've talked a little bit about this throughout, but let's talk a little bit about what are some things that providers can do. So there's a couple of things. One is, and actually this is, some of these are things that could probably be done generally, but kind of came up a little bit more in the context of this population. One is, making sure that one, it tests the technology. And that's really important also because, especially if you're in a clinic that maybe is not located a place that has great broadband, or maybe if you know that the patient is not in a place that has great broadband, having a plan B that's already documented and shared, like before the visit even happens, or starting that way. Okay, if we get disconnected, I will call you back. If the video is bad, we'll switch to audio, kind of letting people know that that yes, things do happen, but we have a plan and we will continue through. So that way you kind of stave off any considerations proactively. The next is looking for and making time and space for opportunities to discuss cultural considerations. Not necessarily waiting for someone to bring it up, because in any provider, patient, or caregiver relationship, people vary to the extent to which they might feel comfortable bringing something up, or to the extent there might be so many medical questions that you think, oh, I meant to talk about these cultural considerations, but I forgot. So really, purposefully making sure that there is time and kind of space to discuss some of those cultural considerations and when they might be accommodated. And so discussing that both in the telehealth visit and in the face-to-face visit, and seeing what can it be accommodated and when and how are important things. And it might be that perhaps during a face-to-face visit, it includes a telehealth component, both to address that. And I think that is a lovely way to try to not interfere with the visit, but to add. The next one is to screen families, not just the caregiver and the patient, but really the rest of the family, and try to connect them with culturally competent services. It did come up a couple of times that there were maybe siblings, or if there's one primary parent, perhaps the other parent, or a grandmother. There are other people in the family who perhaps might benefit from culturally competent services, such as counseling or other types of support. And so, and that could be true for the general population. However, offering a counselor who is culturally competent, that might be the part that's a little bit more challenging. So when thinking about using validated screening instruments that already exists, maybe expanding that use a little bit, or making sure to ask if there are other needs with which the family might be struggling. That can also help with discharge planning, because if someone lives on a reservation, some of the access to things that exist in maybe an urban or suburban area might not exist there, some things that are required for discharge, things like that. And then if necessary, some provider organizations might opt to provide technology. If you know that you've spent all this time and effort getting someone to a certain point, and then you're discharging them to home, which is X miles away, and they don't really have technology or not sure if they're going to come back, it might be worth it for an organization to provide some technology, provide a hotspot, that sort of thing, because it might improve outcomes later, because you can stave off things and not have to have people wait till they feel like, okay, it's worth it for me to come in. Now, I know that those options cost money, so that's something that maybe there is some grant funding for. There's other types of things, but it is something to consider, because it also costs money to have a readmission. So to kind of depending on what the calculus is there, that's something else to consider. So in terms of caregivers, what can patients and caregivers do? So just as the providers have to test the technology, patients and caregivers should too. Make sure that they feel comfortable. Where is the spot in their house that has the right technology? We talk to a caregiver who does visits in the car, because that has the best signal and also the best lighting. So, and also they don't have to worry about other siblings coming into play. So, there's a whole host of things to consider when thinking about testing the technology, and making sure they feel comfortable. You don't necessarily want the first time that you're doing a very emotional type of visit, maybe post-screening or something, to be with a technology you're also not familiar with. And so that's something that providers could provide a little guidance on, and that patients and caregivers can do. Another thing is to make sure that there is a list. And this is something that you might want to do generally, but sometimes with technology, there's maybe a little bit of a lag, or we've all had it where two people are talking at the same time because you think there's a pause, but there isn't, that sort of thing. And then when you're also looking at a culture that maybe values silence a little bit more, it might be helpful to have questions prepared. And also, just as providers should be open to asking, patients and caregivers um, may want to think about, what are the cultural considerations that are the most important to them. People are not one size fits all. Communities are not either. There might be something that, really is important to you, or to a particular patient or caregiver or their family, and other things that maybe aren't really as important, or something that is not as much of they really want to make the effort to do it. And that's fine. And I think that's something that people, as time goes on and there's more highlights on this particular item, perhaps there'll be more openness about it as well, which I think will be great, because incorporating customs and beliefs is an important part in patient and family engagement. And then finally, if there are other types of supports that are needed, siblings, perhaps social supports, some things with this, maybe other needs such as housing, transportation, food insecurity, etc. Those are things that are important to bring up, because they can really impact a person's care, and the literature has shown that these communities are disproportionately impacted by some of the social determinants of health. And so while we talked a little bit about providers and patients and caregivers, there are some opportunities for policy, both at the state and at the national level. And those are things that are maybe more of a long view, but are important to consider and think about. One is expanding the network of providers who are from these communities themselves. It's certainly important to make sure we train providers and that we make sure that the training is kind of expanded. But, nothing really beats having a provider from the community that they serve. And so if there are ways to prioritize recruitment, ways to support people throughout their training, and providers can be providers of all types. I'm not just talking about physicians, counselors, social workers, nurses, and other types of advanced practice providers, really the whole gamut. Another thing is looking at participation in interstate compacts. I touched on this a little bit before, but the way that laws currently stand is that a provider needs a license to practice in the state in which the patient is located. And so if the patient is coming to the provider crossing state lines, it's fine because they're located in the same place. However, if the patient is crossing state lines, which as we know often happens with rare disease, then the provider will actually need a license in where the state is located. There are some interstate compacts which allow for telehealth and some kind of telehealth only licenses and things like that. But there really is a lot of room to expand there. And so some policy advocacy efforts could be to expand the use of those and perhaps make it a little bit easier to get some of those. So those are some things that could expand the use of telehealth going forward. The other is looking at addressing social determinants of health. This is certainly important for SCID families generally, but this population is disproportionately impacted. And so I think it's important to make sure that that the services that are provided are culturally competent and that and that they reach those communities, because sometimes services might be in an urban area and not necessarily reach where people in these communities live. And then also looking at reimbursement. One of the other items that I touched on earlier briefly was payment for telehealth services. During the pandemic, payment parity, so if whether or not face-to-face and virtual services were paid for in the same way, was expanded. And also the types of virtual services that were allowed to be reimbursed, such as e-check-ins, were expanded. It remains to be seen how much of that will continue to expand. Medicaid programs vary, private payers vary, and CMS for Medicare has opted to continue to expand, but not necessarily to the degree that happened during the pandemic. But in order for providers to continue to provide services, certainly the reimbursement needs to be there. So that's another policy consideration for the future. And so with that, I will pause here and see if anyone has any questions or comments that they'd like to share. And then I will also check the chat.
So it looks like we have some questions, some comments. So comments are coming directly to me.
Okay.
I believe that.
Oh, good, because I didn't see anything.
So we have a comment. She says, "This is such an important piece. Thank you for sharing. So many have distrust based on history in our country, and acknowledging that, especially to those individuals directly, is a huge step in regaining their trust, in my opinion."
I completely agree. And one thing I just wanted to point out with that I don't know if I highlighted enough is, in training and in practice, people are so busy. There's so many things that they have to do. Sometimes they feel like, oh, I have to learn about this too. But, if there are resources that can be developed or shared, existing resources that can be shared as part of that training, then that can go a long way, both in expanding the training that's done and then also in disseminating and making sure that people are cognizant of that while they're providing care to folks in these populations. So thank you for highlighting that.
Absolutely. Question, she says, "Is there a service you know of that provides a hotspot at discharge? This might be a great idea for discharge planning when families feel or know it is too soon. Question mark.
That is such a good point about providing hotspots. So I'm not aware of a particular service that does that. However, there are some communities throughout the country where hotspots are provided either by educational institutions, and that came up during the pandemic because the digital divide was such an issue for children trying to access virtual care or virtual school rather. And so that you could use the hotspot for care as well. And also there are some provider organizations that have taken it upon themselves to apply for grants. The USDA had some grants and the FCC had some grants for expanding broadband. And some have used that to provide hotspots. Now, those are all very regionally focused efforts. So that what that means is that there isn't like a national program or anything like that to provide hotspots, but rather organizations or communities applied for grants and then use those for different needs like that. I would advocate, and there are a number of different programs. Sometimes the local ISP or internet service provider has something. If that is an issue, I would reach out to the social worker or care coordinator pre-discharge and see if that's something that maybe they can hook you up with a local resource to provide. Because that, I agree, that's a very important service, and it's amazing how internet, which was once seen as maybe a luxury, has really become a necessity in daily life for so many different things.
Absolutely. Absolutely. So I don't have any other questions. To our audience, feel free to ask any questions. And I'm sure Saira is open to receiving emails.
Yes, of course. Yeah.
Questions after. And I think that concludes. Saira, I really want to say thank you for this presentation. You hit on so many phenomenal paramount points. So really appreciate the presentation. Really enjoyed it. Thank you so much.
Well, thank you all for having me, and thank you all for coming.
Thank you, guys. Okay. I don't see any more questions. So I wish everyone a great weekend and happy Friday. Goodbye.
Bye all.